Friends, welcome back to my channel with a new video, and this is the continuation of the last video about the ancillary therapy. And in this short video, we'll talk about something on aerosol therapy. So, uh, if we talk about the particle size, uh, uh, which is delivered in the form of aerosol therapy. The size is between zero point 0.5 to 2 microns, and the drug deposition is anywhere between 6 to 20%. So, talking about the ultrasonic nebulizers, and of course, the advantages uh, in the form of patient coordination, which is not required, modification of the drug dose and high doses, which is possible. There is no risk of chlorofluorocarbons, as is seen with MDIs. It needs a small dead volume. It is a silent operator. And earlier models were bulky, but the newer models are quite compact and small. The lesser time which is required due to the quicker delivery than the jet nebulizer, and of course the drug loss is less. Looking at the disadvantages, of course, it is expensive and it needs an electrical power supply with the risk of contamination, the non-availability of all the medications in the solution form, preparation of the device which is required, suspensions are not nebulized well, and because of increase in the solution temperature by 10 to 15 degrees, there is denaturation and the degradation of the drug. So these are some of the advantages and the disadvantages of the ultrasonic nebulizer. Now, as far as Aeroneb nebulizer is concerned, which is the standard, the parts which you could see, that there is a connector, the oscillator washer, aperture plate, and the vibrational element. So it's a vibrating mesh nebulizer, which we very routinely use, and it is made up of about 1000 precision holes which oscillates uh, at the rate of about 1,20,000 times per second. The liquid which is drawn through the mesh, and there's a minimal heat which is generated. So this is the very standard nebulizer, and the advantage is the fine particle size, as you could see here in this earlier slide. This is like a mist, which is a very fine particle aerosol. So the Aerono Pro, which you can see here, is an autoclavable device with aerosols in a broad range of drugs. It is usually suitable for infants to adults and no flow added to the circuit, and it is quite silent. The other nebulizers are this Aeroneb Solo nebulizer, and it can also be attached to the ventilator after the YPs. And of course, the benefits are it does not affect the ventilatory parameters, and there is no need to break the circuit. Very simple to use. Now, the talking about the MDIs or meter dose inhalers, which is as a substitute for the ultrasonic or the jet nebulizers or the aeronebs. So naturally they are compact, portable, and a short treatment time. The drug preparation is not required. There is no risk of contamination, and of course the dose reproducibility is very high. And of the disadvantages being it needs to be coordinated with inspiration during the actuation of the inhaler. Device has to be actuated. Upper limit to the unit dose content, and difficult to determine the remaining doses. But nowadays we have a digital kind of monitor which gives a number of doses, so it may not be a problem. There can be a potential issue about the abuse, and all medications which are not available. Sometimes if you want to give one particular drug, then it may not be available in the MDI form. And CFC propellants used in many MDIs is an environmental hazard. So that is the chlorofluorocarbons. And as we know that we just had a talk about the green and the sustainable ICU, and as you could remember that one inhaler, kept, which is in the ICU in the form of say a salbutamol inhaler, which will generate a lot of heat and to the tune of the pollution with a car driven for about 200 kilometers, and that is what I remember. So it is something which is very very crucial and very intuitive for us, to can kind of shift from say MDI devices to say a nebulizer device, especially in ICU, and of course from MDI to dry powder inhaler for the OPD patients. Now it can be of course used along with a spacer, which is an inline adapter, as you could see, and this is the canister. And as you could see that this is inspiratory limb, which is applied before the Y-piece, and this is spacer chamber, which this is the inspiratory limb. So the drug will go in this direction, and this is the expiratory limb. So these are the possible factors which influence the aerosol deposition and efficacy in the ventilated patient. So patient dependent factors are the spontaneously breathing patient, mechanism of the airway obstruction, the severity, presence of dynamic hyperinflation, the dysynchrony, and of course the secretions. The aerosol device, which is the related factors are whether it is MDI or a nebulizer. Ventilator related factors, which kind of ventilator is it, what model, what is the gas flow, and of course continuous versus intermittent delivery. Now the ventilator settings, uh, which are kept in the form of either respiratory rate, the tidal volume, modes, the cycles, the use of inspirative pauses, and of course the flow rate. And the circuit related factors finally is related to amount of the drugs administered, location of aerosol device in the circuit, diameter of the endotracheal tube. So lesser the number of the tube number, there is more resistance, and the patient can have problem related to the aerosol deposition, and of course the presence of humidification devices. So there are few techniques which we need to institute when the nebulizers are kind of delivered in a mechanically ventilated patient. So place the drug solution in nebulizer to optimum fill of about 2 to 6 ml. Place the nebulizer in the inspiratory line, as we saw, at least 30 centimeters from the patient's end. Ensure the flow of about 6 to 8 liters per minute. A good tidal volume of about 500 ml in adults. Adjust the minute volume to compensate for additional airflow through the nebulizer if required. Turn off the flow by or continuous flow mode on the ventilator. Observe nebulizer for adequate aerosol generation. Disconnect the nebulizer when all the medication in nebulization when there is no use, and reconnect the ventilatory circuit and return to the original ventilator setting. So these are few of the very practical tips which we can use when a nebulizer is used in a mechanically ventilated patient. Similarly, there are techniques for using MDI. So again, ensure a good tidal volume, aim for an inspiratory time of more than 0.3 of the total breath duration. Ensure that the patient breath is synchronized with the patient's inspiration. Shake the MDI well and place the canister in actuator of the cylindrical spacer, which is in the inspiratory limb. Actuate to MDI to synchronize with the precise onset of inspiration. Allow a breath hold at the end of inspiration for about 3 to 5 seconds. Allow passive exhalation and repeat actuations after 20 to 30 seconds. So very practical points as far as the use of MDI is concerned. And as you could see, that the effect of position of the ultrasonic nebulizer and a small volume nebulizer. This is of course the inspiratory limb. So this is where just proximal to the Y piece is ultrasonic nebulizer. A little distal to that would be a heated humidifier, and distal to that would be a small volume nebulizer. So these are the typical sides of various devices which are placed in the inspiratory limb of the ventilator tubings. And finally, there are devices for the aerosol therapy in NIPPV, especially when the patient is on non-invasive ventilator. So you use MDI like a spirally device and of course the mask, and the nebulizer which is directly placed on the NIV mask, and this is nebulization tracheostomy tube adjunct, and this is a device which is called as a spirally device. So I think this was all about the aerosol therapy, and that's all for now. Let us meet in the next video, and probably that would be the final video in the series of the ancillary therapy. And so take care. Bye bye.